Hello and welcome to the Doc Podcast. I'm your host, Dr. Mike DeLuke, and it's my mission to help you lead a happier, healthier, and more prosperous life, both personally and professionally. Hello and welcome to this episode of the Doc Podcast. Today, I'm joined by Dr. Suraj Vatish. Dr. Vatish is an implant surgeon who obtained his postgraduate diploma in implant dentistry from the Royal College of Surgeons, Edinburgh. After placing over 5,000 implants, he found that his true passion is helping patients overcome the challenges associated with tethered tissues. Dr. Vatish then went on to complete extensive surgical training in advanced frenectomy techniques and is affiliated with the Zagi Institute. He is now recognized as one of Europe's leading providers of tongue and lip tie releases, having performed thousands of successful procedures for babies, children, and adults. Dr. Vatish also teaches clinicians around the world, sharing his expertise in tongue tie assessment, surgical techniques, and post-treatment care, all things we will be talking about during today's show. We will also discuss how and why Suraj made the switch from placing implants to focusing on releases, the importance of obtaining a thorough patient history, the different types of tongue tie and how to determine who can benefit from a release, the benefits and challenges associated with releases in different age groups, the 3 pillars of health that Suraj uses to evaluate all his patients, the link between tethered tissue and airway issues, the importance of interdisciplinary care, including the critical role of myofunctional therapy, both pre and post-release, the 2020 consensus statement from the American Academy of Otolaryngology Head and Neck Surgery, and much, much more. To be completely honest, when it comes to tethers and releases, I am still learning a lot myself. As with many of you, I was not taught about this and had to learn it throughout my time in practice and really didn't focus on it for many, many years. I'm now gaining a greater awareness of the role that tethered tissues play in the overall approach to patient care. And I recognize that there is a great deal of confusion on this topic, which is why I wanted to bring in an expert to answer the questions that I have, as well as those that I am often asked by others. Whether you are already a believer in the benefit of tongue tie releases or a skeptic who thinks they are overdone and often unnecessary, you do not want to miss this episode. As always, please share the show with others, friends, family, colleagues. That is the best way to continue to provide this education to the public on these topics that are so important to what we do every single day. So without further ado, let's get on to today's episode with Dr. Suraj Vatish. Enjoy the show, everybody. Welcome to the Doc Podcast, Suraj.
Thank you so much for having me, Michael. It's such a pleasure to be here.
My pleasure. We were just kind of talking with you being in the UK. I appreciate you doing this at different hours, being 4 hours apart from here on the East Coast and the connection challenges of the world of technology. So thank you for working it out to be here for the audience. I appreciate it.
No, thanks again. And it's funny that, being so far away, we can actually almost be like we're right next to each other. It's got a lot better than before, but still got some improvements to do.
No, it's true. It's great we can even have this conversation across time zones like this. I guess one of the good things that came out of COVID, right? We weren't thinking in terms of being able to do these things at this point 6 years ago. So you have an interesting story. And before we get into talking a little bit more about what we're going to talk about today, a lot of it being what you do in clinical practice, especially when it comes to tongue tie releases and tethers and how that fits into a practice and what you've essentially focused on doing at this point. Tell the audience, if you would, a little bit more about your journey, your story, and how you got to be to where you are today.
So my story is a very strange one. Coming from that, I actually, in training, I'm an implant dentist, and I did a lot of training in oral surgery. And if you were to see me about 7-8 years ago when I started this journey and told me I'd be working with children, treating tongue ties, etc., I would think you're crazy. Like the fact that I even see babies now, even sometimes you kind of I look at myself like, what the hell's going on there? So what happened was I did my surgical training. I started to work in a practice in central London, and my business partner asked me to start looking at doing some tongue tie releases. Now, I tell everyone the story because I did a few tongue tie releases in my surgical residency. I had a mentor who showed me how to do it with scissors. And I hated the procedure because it bled. It scared the hell out of me because the floor of the mouth is one of those areas that you don't really want to be messing with. And I said to myself, no, I was very hesitant. Then she got me to do some training in the States with Dr. Baxter and Dr. Zaghi, the Breathe Institute, and my whole world changed from that point onwards. It's now got to a point that I'm only mainly doing tongue tie releases, airway-based dentistry, and my implants and oral surgery in my spare time. So it's a complete U-turn for me.
Did you find that when you made that transition, you were drawn there because you started seeing something that was a need, or did it just become something you became more passionate about and enjoyed doing more than, say, the surgery, implant-related surgery, or a little bit of a combination?
Great question. So doing implant surgery isn't really, you don't feel any kind of job satisfaction. You've given someone a tooth they're able to chew on, but it's actually very mechanical. When I started doing tongue ties, and especially treating babies and seeing the mother, so you see these parent families come into you, they're struggling with nursing issues, and you see them within 1 week and they're a different family. They're so happy, they're so grateful for what you did. And what people do say is how a such small tone of the tongue can make a huge difference. But the difference I do see, and what kind of gives me the motivation to do what I'm doing, is a child being able to speak easier, express themselves a lot easier, a baby being able to nurse and latch better, and all down to the very quick wave of a laser.
And I guess I don't want to get ahead of myself here. I have so many questions of things I want, because I don't know. I'm very open to my audience about anything that I am doing or have done in my career. And I will admit, I didn't really know much about tethers. If you had asked me, 5 years ago, the difference between an anterior and a posterior tongue tie, I couldn't have told you. I look back at cases I treated years ago, even when I was doing early arch development and expansion and making room for the tongue and normalizing that anatomy. I look back at some of those cases, and I have really good documentation and records before and after treatment, and oftentimes during. And now I see in some of those cases where post-treatment, the tongue never fully was up into the palate, whether it be on CBCT, which I know is just a static image. We can't necessarily judge function, but you can tell if that tongue can at rest just comfortably fit up into the roof of the mouth or not, or if it's kind of stuck between. So you'd get good expansion, but you'd still have a little bit of high vault into the palate, right? Where that tongue sits up higher than it did before, and it can get up toward the palate, but it can't get quite all the way up. Or those cases that in between phases weren't quite as stable. And when I do my early arch wire expansion and development, those are so stable when you get the oral facial musculature in balance and you create that equilibrium that Enloe talked about, Mel Moss talked about, right? They get that balance of forces. And I look back, and honestly, Suraj, I look at some of these cases and I'm like, oh my God, they had a tongue tie. And that was the problem. And I never recognized it. I never understood it, because we really don't learn about this, just like a lot of the things that we have talked about and will talk about today. So when you started looking at this, let's just start first, maybe break this up for the audience. We'll start with diagnostics, then we'll get into the treatment side, and then we'll kind of get into the follow-up or the exercises, myofunctional therapy side that needs to be concurrent therein, if that's okay. So starting first on the diagnosis side, what are you looking for? Are you using Zaghi's criteria? Do you have your own parameters you use? How much of it is based off of patient and parent reports? And I realize this could be different, whether it's an infant latching or a 6-year-old with a strong tether that is having speech issues. But if you could just kind of paint the picture for the audience of, generally speaking, at different age groups, what are you looking for to say, yes, this patient not only has a tether, but a tether that is causing problems?
You know what, Michael? I'm exactly in the same boat, because last week I actually looked at one of my old implant cases and there was a massive anterior tie there. And I'm looking at myself, I was like, how the hell did I miss that? And you're right, We're not trained to look at tongue ties. In dental school, especially in the UK and Europe, you're only kind of trained to look at teeth, look at a bit of crowding, look at the gums, and that's it. You don't really look at the wider kind of tissues in the mouth. And if it's not an anterior tongue tie, people are like, it doesn't exist. Especially, that's what I learned at university. Ankylosing is always a tie of the tongue. But on my eyes and what I've seen in my experience, there are so many different types, and it's not always black and white. Now, this is where I would say practitioners debate a lot, because the term mild versus severe, so for layman's terms is if you're looking at an anterior tie, people would call it severe. If you're looking at a posterior one, people call it mild. Now, whilst it's kind of true in some ways because you're talking about where that kind of impact of the restriction is to the base of the tongue, it's a complete different matter when it comes to the patients. So what I tell people when I'm teaching about tongue ties, I was like, number one, you need to speak to your patients. You need to, when you're treating a baby, you need to find out from the parents what issues with nursing are happening. Is there any pain on latching? Is there any clicking noises? Is there any colic, reflux? And it's so important to get a full, complete history before you even examine the baby. And that's what a lot of my time when I see a patient, first of all, is creating a story, finding out what's going wrong. Sometimes the mothers will come to you saying, something's just not right with this baby. So that for me already, my alarm bells already ring thinking, okay, why is this mother concerned? Because mother intuition is our oldest medical tool. And if we didn't rely on it, we wouldn't be here as a species. So when I'm treating infants, and we'll put kind of infants and toddlers in that kind of bracket, the first thing I'm looking at obviously is symptoms. When they get to the toddlerhood, we look at speech issues. Oh, my child's not speaking too well. Oh, they're not walking, or they just literally jumped up from not walking to walking, or they miss crawling, or scooching on their bum. So small little stories paint the picture when you talk about restrictions, because these are usually down to the fascia. But the classification scale I use from babies to toddlers is the Kotler scale. And I explain it to parents in a very, very simple way. I'll say to them, now, we look at the tie. Imagine if I was to tie both your feet up with a shoelace. Now, that shoelace can be very long, and you can have some movement between your feet, or it can be very short. And the idea is a tie is very binary. It's there, it's not. And what you have to kind of understand as a practitioner is this patient compensating or not. And when we talk about compensations, this means that that patient is working 5, 10, 20 times harder to compensate for that lack in function. And whilst commonly thought, and this is obviously my own clinical experience, not in studies, but most of my patients with symptoms come to me of the posterior ones or the mild ones rather than the more severe or anterior ones. When I look at an old... Yeah, it's one thing that, you think about it and you're like, actually, shouldn't it be the other way? But don't ask me why. I think it's because they use their jaws over, if you've got an anterior tie, the tongue and the jaws are joined up a lot more. They're probably using their jaws a lot more to compensate, and that's probably a bit easier. But I'm sure probably Dr. Zalgi could answer that better than I could. When I've got an older child or an adult, the one thing I'm looking at is how the tongue lifts without using the jaw. So it becomes a lot easier to kind of see, because you get the patients to open their mouth really wide and without closing their jaw, lift their tongue up to the spot. If they're using their neck, so you might see a lot of adults like tensing their neck there, there's some sort of restriction there. And then Dr. Zalgi is also showing us the floor mouth hold. So you put your fingers just over and try and see if the tongue lifts up. In so many cases, you see they might even get the tongue to spot, but as soon as you put your finger there, it drops down. And that for us is a tie then at that point. So it's the classification and diagnosis vary a lot. And that's where, I believe it's all about giving patients and families information. Yeah, you've got a tongue tie. At the moment, we may not have any symptoms. At the moment, we have these symptoms, X, Y, Z. This is what to look out for as you kind of, as the days go on, etc. This is what you could be more predisposition to.
Thank you for explaining that. And a couple of things I'm struck by. One is a common theme and an underlying theme in so many of the guests I have on the show who think about things differently than, as we had said, we learned about in school, right? In dental school, medical school, whatever the case might be. And that is the time you spend in the diagnosis and the history. And I find that to be oftentimes the case with people who think differently about things. We learn, and as I teach residents actively, I was just in a seminar teaching residents this morning, we spend so much time in my talk this morning for 2 hours. I was basically just talking about the diagnostics. That's it. We spend so much time in school on diagnostics. We get out And we forget, now I should, as a caveat, a lot of what we learned in dental school and diagnostics wasn't necessarily the things we're talking about now, but the concept of needing to know your patient, diagnose your patient, understand was really there, at least in the dental schools in the US. We get out and we just want to do. We just want to treat right away. And we try to almost get through the diagnostic and the history process as fast as we possibly can to be able to do something. And I think, totally my opinion, and it's somewhat skeptical, but what do we get reimbursed for? I mean, sadly, what we do tends to follow reimbursement. We don't get paid to diagnose. We really don't. In the US, we don't even have diagnostic codes necessarily for the dental profession. It's treatment codes for sure for orthodontics. I mean, you just know what their malocclusion is, and then you just put a treatment code in. So I think that's a big part of it. So I was struck by the fact that you focus on the history and the story. So before we get into sort of the more treatment side, what would be an example of maybe first of a little one, infant age, parent comes in and they're having trouble nursing, and then another example of maybe a pre-adolescent, sort of in the transitional dentition patient. If you could just give an example of each of those patients, and then, I'll tell you what, Suraj, if you're okay with it, do an adult as well. Maybe those three, what are some of the things that you're looking for in their story in your diagnostics that will help you?
Good. Great question on that side. So just to support your point, in the UK, we have the NHS system, which kind of gets dentists giving 15 minutes to a patient. So they get out of dental school as well. I think that we're not very history heavy here. It's more like diagnose decay, treat it, get the patient in and out. You've got 15 minutes. And it's one of the things that I find so hard to explain to new graduates, because you're right, we finish school, we just want to go ahead and treat. And it's definitely changing your mindset at that point to kind of speak to your patients a bit more and understand and build a connection, because that's what we're there to do, is also help them. Now, to kind of tell you what I would be seeing in, let's say, an infant. So the first the way I break it down anyway, is what I call 3 pillars of physiological health. So as an organism, we all need to sleep, we all need to breathe, and we all need to eat. And later on, we all start speaking. And I use these 3 kind of pillars to help guide my diagnosis. Now, when we look at the eating side, especially very common in infants, because that's the kind of the first point the parents will come and see for a tongue tie release, or to understand what's going on, because usually this infant is having difficulties nursing. They're falling asleep during feeds. They're very colicky, gassy, refluxy. Mothers may have maternal pain because of the compensations. Or maybe even they've noticed that their infant is really tight, and on that side they've seen an osteopath to kind of help loosen them up, and the osteopath's like, what's going on here? And then thirdly, the most serious one is maybe they're having difficulty gaining weight, which is where we get very worried there. So these are the kind of things that I always tell parents to look out for when they're nursing. Is your child constantly falling asleep? Because number one, that's showing me that that child is not getting the energy they need from a breastfeed. Because it kind of, when you start using your jaws, back of the neck to compensate for lack of tongue motion, you end up turning feeding into a loss of calories rather than a gain. So a lot of people a lot of children really struggle with gaining weight at that point. But sometimes the mother supply compensates. And so gathering a history at that point is a lot about breastfeeding. And sometimes you might even see the similar symptoms with bottle feeding. A lot of parents come to me because breastfeeding was either not a personal choice or didn't happen, which is also a red flag for me to think, why did breastfeeding not happen? And then they're like, well, my child clicks a lot on the bottle, or milk leaks out every time you have the bottle on. So already I'm thinking in my head, I've got my check sheet, which I give patients, and if they're checking off about 4 or 5 ticks, we know that there's something going on, whether it's the tongue or lip or something in harmony. We know that we're already getting ready to screen. Now, when we've got a toddler, it's a bit different, because what I kind of see is you see the more longer impacts of a tie there. Now, one thing which is unanimous throughout all age groups is commonly mouth breathing and sleeping. So a lot of times parents will even say for the infants and toddlers, they snore a lot or they're mouth breathing all the time, and you just see their tongue all the way at the floor of the mouth like this. And this is, for me, we got to ask ourselves the question, why? Because we are not born to be mouth breathers. We're born to breathe through our nose. We're born to, and the nose is naturally there to filter, heat all the air. And unfortunately, maybe in Florida, the air quality is a lot better. But here in central London, we have very poor air quality. And if you breathe that in, there's no filtration mechanism until you get to the tonsils around this area. And then at that point, you start seeing more of the other mouth breathing effects. But in a toddler, I would look for if relative to speech issues, are they having difficulty speaking, babbling, mouth breathing when sleeping, mouth breathing throughout the day. One of the other factors I find a lot is prolonged dummy use. So parents who are just, these children who are so addicted to the dummy, and we've got to find out why. And then also we can look at a bit of the milestones at that point. Are they hitting their milestones well? Do they crawl? Do they walk well, etc.? When we get on to the older children, then it becomes a bit more dental related. So these are when I usually get the parents, because they've seen an orthodontist like yourself who's very airway aware. They've said, okay, you've got a tongue tie here. This is going to help support my result as well. Or it can be due to speech issues, there are difficulties with R's, S's, L's. We get a lot of patients who lisp, and we're even seeing some links, myself and my speech therapist, between stuttering and a tongue tie as well. And we've helped a lot of children overcome their stutter by treating the tongue tie. And the other factor we also get at that point is, like I talked about, the dental issues like crowded jaws, mouth breathing, but a bit more like an anecdotal one is a 16-year-old came to me because they couldn't lick an ice cream. And they said, my whole life I've been trying to lick an ice cream and I can't. And it turns out they were completely tongue-tied. But they had no other symptoms. They could speak 3 languages. They even had a very broad maxilla there, but it was just the pure function of the tongue was very limited.
Yeah, it's interesting. And actually on so many things you say, I'm thinking make me have other questions in other areas. So thank you for taking the time to go through this. A lot of this is me asking questions to learn, hoping the audience is going to enjoy it as much as I am. Although I do know a lot of the questions, as I said, that I get when I'm out there speaking or through my contact channels and social media are about this topic, because it doesn't seem we get a lot of education on it. And we are all just trying to learn. And I think, just like with anything, I say this with the early treatment side of orthodontia and dental facial orthopedics, there are people who just treat everything. And that gives the whole movement a bad name, because to me, those people, they're doing the same thing, just on the opposite side of the spectrum. They're not taking the time in diagnostics. They're not taking the time in understanding the story. They're just treating everybody the same way. And it's like, oh, you come in and my protocols are, we put expansion devices in any patient who comes in at any age. Not taking the time to understand why. As in, a lot of people you'll hear that's like a tongue tie factory, right? Like everybody who walks in, they're doing some release on. So what a lot of us hear about this, I think it's just like in anything. There's going to be bad in any aspect of any profession or life, right? No matter whether it's politics, religion, the professions, sports, it doesn't matter. We can't judge the whole by the extremes. And so I always tell people, yes, there are people out there overdoing anything in life. That doesn't mean that it's not valid to be helping in some capacity. So what you just described in those stories are people whose lives you truly changed. The tough part is there are people on the opposite side of this discussion and debate who say it's much ado about nothing. And it doesn't really make much of a change. They have, as you said, the people compensate. They've compensated. There's more harm that can be done than good when you do that release. Now, again, not the infants. Infants, people seem to be pretty clear, like, if it's latching and they can't latch, that freeing up that tongue can have a benefit. I'm talking about as you get a little older. What are some of the reasons why you believe and what you've seen? Well, I guess let me ask this first. How do you know what's severe enough to treat and what's not severe enough to treat? And then what are some of the responses you get in your patients that you see afterwards, beyond the infants and the toddlers, sort of that next age group of, let's just say, kiddos right now that you provide a release for? What are your outcome measures?
So, Michael, great point there. Now, what I tell everyone, especially in the medical community, let's look at webbed hands, which is the same kind of restriction as a tongue tie. Now, if someone's born with webbed fingers, would you tell them, grab this glass however you can, like this, and let's see how you got on with that through your life? No one even thinks twice. They release the fingers because we understand how important the dexterity is to us. And the same goes with the tongue in my eyes, but it's very overlooked because I think there is a huge debate on whether or not a restriction exists. People don't really, like the big debate is about the posterior mid-blade restriction. How bad is it? How far should you go? Etc. Because anteriors, most people won't really debate about, but in posterior mids, everyone does debate. Now, and that's where Dr. Zaghi's floor the mouth hole test works really well, because it's very, in my eyes, clear cut. Tongue's not getting up where it should be. You're using these muscles. You're compensating. Very clear. Now, when you see a child who's kind of been told by everyone, I've seen this a lot of time, that this tongue tie is mild, where sometimes it's not, but just say, oh, I've got one, I've survived really well till right now. We're not questioning the survival of a child there. But imagine that you're this child and you're going to school. You're not sleeping well because you're more prone to mouth breathing. So already you're at a disadvantage because all your peers will be getting a lot more better sleep. Then when it comes to speaking, you're struggling. So you might have difficulties with R's, S's, L's, TH's, ING's, or you might have a lisp, or you may have a stutter. Now, already this child is having some injustice to them in my eyes. We then take this a step further. We then look at the social impact it's going to have on this child, which is how are they going to fit into society if they're not sleeping well or speaking well at this point? And then we look at the further impact on their digestion because they're not able to swallow well in some cases, so they're not getting the nutrition they need. Now, of course, they're still going to be breathing because we will measure baseline by is that patient surviving, etc. But survival and surviving and thriving are two different things. We're all made to survive, I agree, but thriving is completely different. Now, when I work with speech and language therapists, and they have all started, the ones we work together with, they start to change their opinions because historically they're taught, put this child through months of speech and language therapy, and if nothing improves, there's something wrong with the child. And I was speaking to one of them, Katrina Rogers, who works very close with me, and she honestly started really opening my eyes. She said, you don't see the face of these children when they're told they just can't speak too well or they can't do anything on this side. And that really is heartbreaking because you're just writing those children off. But then if you identify an oral restriction and then you treat that, then all of a sudden, bam, the child starts speaking a lot better in the next few weeks. They start pronouncing things a lot better. Their stutter almost reduces. You've really made a big difference rather than just putting them through months of therapy where they're already at a kind of disadvantage because that tongue's not moving too well. Then when you look at adults, it's a very different story because these adults are the ones who are chronically grinding their teeth. And when I used to do implants and restore them, these would be the patients I'd hate because you would place a nice implant, a really good implant crown. They come back to you in 3 months because the crown's loose because they're grinding it down. Or the implant components start breaking. Restorative dentists also find them very tricky because they're completely they've adjusted the occlusion perfectly. They've done everything, so this patient shouldn't be grinding, but they're still grinding. And these are where these adults, because of the fascial tensions in the tongue and the jaw and the compensations going on, will carry on grinding until you look at the root cause. And then we have also the sleep and airway related part. Now, if you have a tongue tie, studies are showing that you're 3 times more likely to snore. And what we kind of see is that tongue falls back into the airway at rest and blocks it. So you almost have a lot of restriction going into that airway because that tongue is blocking the flow of oxygen when we need it the most when we're sleeping. So these adults then start having very light, broken sleep, or they're kind of on the apnea scale as well at this point for that reason as well. And those are the ones where obviously we need to take a very holistic plan of treatment because unfortunately, I will be very honest with you, fixing the tongue tie alone is not going to fix these patients. They're usually very compromised in the maxilla and they have very narrow jaws, and that also needs to be treated. Plus seeing an ENT to make sure there's no deviations or blockages in the nose as well. But I wouldn't treat a tongue tie just purely for sleep apnea unless we are part of a bigger team at that point.
Thank you for clarifying that. And this brings up such an interesting point, because a lot of people who are skeptical of the relationship between tongue tie release and airway, I'm sure you know of it, the American Academy of Otolaryngology head and neck surgery, right? So, yeah, exactly. This is how you're probably thinking what I think when people say the American Association of Orthodontists white paper from 2019, except in this is the AAO HNS as opposed to just AAO, ironically, but out of clinical consensus into 2020, which talked about ankylosing in children. And one of the points that they were pretty profound to make is, well, we really don't have much evidence on any relationship between tongue tie and airway. Yes, for breastfeeding, there can be benefits to it. And this is ironic because it's eerily similar to what the AAO said on orthodontics and airway, which was, we know that people say it's kind of a thing, but there's really no evidence, right? But if you look at the study, they really didn't. I mean, they didn't say it's not a thing. They really just said there's not a lot of evidence or a lot of research done out there to necessarily quantify it. And as Ellen Stothard, who's on my show recently, said, who's a researcher working with Dave McCarty and his group at Rebus, absence of evidence isn't evidence of absence, right? So it just because we haven't done the studies on it doesn't mean it's not a thing. So what do you say to people? And then JADA put out something in 2024, which was kind of similar, saying that the conclusion is we really just don't know that this is actually related to airway. I'll leave it to you. What are your thoughts on that? How do you answer when people say that?
So my mentor and good friend, Dr. Baxter, always tells people this kind of analogy. You don't need an RCT to prove the efficiency of a parachute when jumping off a plane compared to a bag of clothes. And
right.
It always makes us all laugh, because you're not going to get 5 people and be like, all right, you have a bag of clothes, you have a parachute, push them off the plane and see what happens. We kind of know with our clinical experience what kind of is relative, what works and what doesn't work. And another one of my old professors in Valencia is really taken to this whole tongue tie and sleep apnea and kind of snoring and sleep disorder breathing. She's publishing a lot of studies. Her name's Dr. Rocio Marco. And the study I quoted where he said, if you've got a tongue tie, you're 3 times more likely to snore. She published that study looking at, I think it was a retrospective study done on on some patient population groups. But the one thing also I see in my practice is with infants is you treat a tongue tie and they stop mouth breathing almost within a couple of weeks. And if it can work for an infant and you're doing the right things with an older child, you'll have the same effect. Now, no one's saying you're going to completely fix the airway. No one's saying you're going to change everything, because the airway is very dynamic. But reducing the stress on it is only going to help you in the long run. So when we look at, for example, the actual frenulum, because it's all fascia, it's connected down, there's so many different ways it could potentially be causing an airway issue. It could be the fact that the fascia is linked up to the hyoid bone, which kind of limits its movement, and you kind of pull the jaw forward. That could be one thing. It could even be the fact that the tongue's falling back with the airway because it's lacking that tone. Now, what we always have to look at is what's the best option, what's the best way to treat it. Is it some patients, especially the adults, because they're so lacking in space and they don't want to go down the orthodontic route, I advise them just to do myofunctional therapy. If they don't have enough space for me to release that tongue, myofunctional therapy alone is going to train that tongue to hold it up into the palate, sit less in the airway. Or I send them to one of the ENTs who put the implants to kind of push the tongue out of the airway, which is an accepted treatment. So when we look at all the differences, I think the ENTs, I was in a conference in India last year, and they were showing me all of these surgeries they do to treat sleep apnea, which is resect the soft palate, basically cut it away so then that's not blocking the airflow through the nose, and put an implant in the tongue to kind of pull it out the mouth and push it upwards. And I saw that and I was thinking, pulling the tongue upwards and almost upwards is basically myofunctional therapy, but do you need an implant to do it, or can you not get the patients to do therapy? But that's, I asked that question, they said, yes, myofunctional therapy, they're starting to accept it because they're kind of getting better results for their treatments as well.
And what about people who say, actually, I'll come back to a couple of things on the randomized controlled trial side, because I love what you said and I completely agree. What about people who say that the release in an adult could cause, or in any person, and I don't know if this is just because it's in the absence of myofunctional therapy. That's always kind of been my assumption from the literature I've seen. If you just take, especially an adult or an older child, and you just do this, or even a younger child, and you just do this release, and you don't have concomitant myofunctional therapy, the tongue doesn't know where to go. All those compensations, it'd be like the analogy you use with tying the lace around the person's legs. You free that thing up, and they don't know how to put one foot in front of the other, they're going to fall on their face. So because all the musculature is compensated. So am I thinking of it correctly that when it can cause an airway issue, because a lot of people who are on the opposite side of this debate think, or will say, well, it can cause obstructive sleep apnea, and I believe that was even lightly referenced in that AAO HNS paper. Is that what's really going on? Is if you just release it without the appropriate myofunctional therapy and orofacial musculature breaking from those compensations, that the tongue is just too loose and too floppy, and it literally just falls back into the airway at night?
Precisely. And that's why, number two, it also leads to higher rates of complications and reattachment and surgery. Now, throughout my journey, I have performed tongue tie releases without myofunctional therapy and with myofunctional therapy. And the difference is tremendous when you do it with myofunctional therapy before. Now, and it's in a good way. So the difference is with doing myofunctional therapy before release, you prep that system for what's about to come. You're creating new nerve connections between the brain and the tongue, which are always there but never been used too much. The patient's already knowing what they're kind of going to get from the release. So you're kind of already getting a post-op surgical outcome before you've even cut the tissues, because you can kind of see, okay, the tongue's holding itself up. The only downside is that they need to be doing the therapy indefinitely, because that tie will then pull the tongue back down and they'll kind of lose that muscle tone they've built up. What I've seen in my past is when you don't do myofunctional therapy and you do a tongue tie release, you're just throwing the system off completely. You're basically like going back to the shoelace analogy. You're basically cutting that shoelace and telling that patient, go run a marathon without any training. Now, there are some people who can do it. Like I say to some people, I was like, people with one leg I've seen doing incredible things. I said, me with two legs, I can't even do half the things they do. And I've got technically an anatomical advantage, but this is where the internal genetics or compensations of a person come through. And when you reset a system like that without doing the pre-op work, so making sure, number one, there's good tongue space, with the orthodontists usually are creating that space for me, you're setting yourself up to failure. You're setting the patient up to be completely dysregulated because they don't know where that tongue's going to go. You're setting your surgery up to fail. And instead of going in to make things better, you're going to make things worse, unfortunately. So those are the reasons why when I treat an adult or when I treat an older child, I'm always working with an orthodontist and myofunctional therapist, because that tongue needs space. And if it doesn't have space in the mouth, it's going to go full back. It's basic physics. We don't really need an RCT to tell us that. You've got to think the mouth has limited space. Same with extraction-based orthodontics. If you're pushing the teeth back, where is the tongue going to go? It's going to go back into the airway. It's not exactly going to be sitting up in that space, is it?
Yeah. I'm glad you said it, because my next question was going to be about OMT and myofunctional therapy and the role that plays. And I think that's one challenge is it's the biggest challenge of this whole thing. And I say this all the time. The etiology of this sleep disordered breathing is multifactorial. It's heterogeneous. And as a result, the solution has to be multifaceted and multidisciplinary. And when we just think, that's why when the article, the American Academy of Dental Sleep Medicine came out in 2024, I believe, with that statement that no single monotherapy works to treat or solve airway problems in children and adults. It's like, it was this big thing. A lot of people are like, see, we told you expansion doesn't work or releases don't work. It's like, no, that's not what it said. If you read the article, it said that there is no magic pill, right? There's no magic bullet that we can just always, if you do a release, patient breathes great. If you do expansion, patient breathes great. In a coming episode is with Dr. David Gozal, and he talks about the fact that there is no single thing that will solve this problem, right? That's what makes it hard. That gets back to what we talked about before, which is the time you spend in your diagnostics. If you just go in and release everybody, but they are narrow with a high vaulted palate, right? And poor orofacial muscular tone, you're setting that patient up for failure. And then if you just look at that patient's sleep and airway, of course, it might be worse as a result of that. And now you could say, oh, the release caused the problem. Well, did it? Or was it the fact that you didn't have the right support around it, right?
100% agree with you on that side. It's very easy to promise golden bullets to patients and say, this is going to cure everything, this is going to do that, etc. And unfortunately, we could be further from the truth. If things were that simple, like I say to a lot of people all the time, if my patients could just take their mouth out, leave it with us, we could move the teeth, we can fill them, and they come back in the evening and we put it back in, you and my life, Michael, will be so much easier. But unfortunately, everything is all connected. And especially if you're treating one part is not going to change someone's life. And unfortunately, I tell a lot of adults this. I say, treating your tongue tie only isn't going to make your life different. It's a process. And the tongue tie release works as part of this process. The other part is, like I always mentioned, seeing a good orthodontist, getting your upper jaws expanded if that's the case, seeing a myofunctional therapist, also seeing a body worker like an osteopath or a chiropractor, because you're also going to be holding tension in the back of the neck and jaws from these restrictions that you've kind of grown up with. And just by me releasing the tongue in the short term, yes, you get a bit of relief, but then these muscles have been compensating for however many years, and then when they're going to go back to where they feel comfortable because that's what they've always been doing. And It's never one thing. I wish it could be. You and I both wish that by doing one treatment we could fix the world, but unfortunately it's definitely that's why we love working in teams, because I will do one part, you probably will do another part, and then we'll have someone else doing another thing. And it came back to a very interesting point that you said before, where someone will come in and do everything. And I kind of have the philosophy that do one thing, but do it well. Like, you are probably one of the world's greatest orthodontists right here. I would be doing my patients a disservice if I was next to you and basically trying to do orthodontics instead of sending them to you. I would say, look, go and see Michael. He's a great orthodontist. I'm going to focus on the tongue tie, these tissues, see my myofunctional therapist. We all of us kind of stay in our lane, and then we're all answerable to each other. Because then if I do the expansion and I do the tongue tie release and I do the myofunctional therapy, I'm kind of in some ways blinding the whole process as well. So I'm kind of thinking, okay, this patient should be fine. And I see this a lot in the UK with, unfortunately, midwives and lactation consultants doing the body work, tongue tie release and lactation, where the parents get very overwhelmed with one person doing everything, which from a convenience point of view is nice, but then from an actual scientific point of view and best outcomes for the patients, it's not the best way forward.
Yeah, jack of all trades, master of none, right? It's so hard and the biases, as you said, you see things, you don't have that other set of eyes or multiple sets of eyes to be able to help you. And that interdisciplinary care is something we also don't get in our schooling. We don't. I mean, I've always marveled at the fact that in orthodontic residencies or pediatric residencies, oftentimes, not always, you are like right down the hall from other residents and other students, and the medical providers are usually in the same building or nearby, and yet you literally just pass each other in the hallways. When I went to dental school at Stony Brook, we did our didactic, our classroom work. The first 2 years was with the med students, but after we did all of the classroom work with them, we split. We hardly ever saw them again, and yet we should be doing rounds with them. We should be working hand in hand with them on patient care. So yeah, I agree with that as well. And the other part, which you'd mentioned that Dr. Baxter had said as well, the randomized controlled trials. My audience who listens often is probably sick of hearing me say this, but for those who haven't heard this, for those newer listeners or for those who haven't heard this, I say all the time about Sackett and evidence-based medicine. And when he designed it, the concept in the 70s and 80s and named in 91 by a student of his, Gordon Guyat, he specifically said it is not restricted to randomized controlled trials and meta-analyses. Specifically, the founder of evidence-based. Yet when you ask most people what they think evidence-based is, they think, oh, it's got to have a randomized controlled trial. And it's so much so that John Ioannidis from Stanford wrote a great article a year after Sackett passed in 2016, talking about how evidence-based medicine has been hijacked. And that's what you see happening a lot of times. I mean, the conclusion of the article from the AAOHNS was basically that they need more research right away. Well, okay. But Ellen, who I referenced before, who was on my show, is a brilliant PhD researcher. And she said, you can do clinical analysis of data, and it still is valid data. And that's what Sackett said at evidence-based too. It's just that RCTs, systematic reviews, meta-analyses are the highest level of research. But the important thing for people to understand is Sackett defined it very clearly as a triangular epistemology of three equally sized circles, so to speak, but three equally sized components, which are the research, sort of the science, the data, the patient values and preferences, and the clinical experience. And you have said many times throughout our talk so far today about what it does for the patient, right? Their values and preferences, how it changes their life. And you've talked about all of your clinical experience. Those are also valid. And Sackett says when we don't have the correct evidence-based, quote unquote, as people say, or randomized controlled trials, when the correct scientific data are not there, it is our responsibility to not deny treatment, but to then look at the other parameters in an effort to provide the best level of care to that patient. And I feel like a lot of our organizations, our bureaucratic establishment organizations, they just want to have the final say, whether it's authority, power, whether it's they don't want to change. It's just easier to say there's not a study on that, we don't recommend it. Instead of actually doing the work to look into, number one, how about you help the schools design the studies, right? And I know you can't do a randomized controlled trial, like you said, on the great example with jumping out of a plane. We can't, for reasons of equipoise, no IRB or whatever the comparable is in the UK and Europe is going to allow you to withhold treatment from somebody who you know could have a benefit. But that doesn't mean we still couldn't run huge data analyses of sample sizes, set up objective parameters of before and after. Just look at your patients with releases, right? Have them do which you're doing already, a clinical inventory of symptoms, a clinical inventory of quality of life measures. And then you look at that before, during, and after. And according to Ellen, who again knows more about research than I'll ever know, she said, those are valid data. They are completely valid data. We just, because when we're clinicians, sort of wet-fingered, as we call it in the US, and we're with our heads down working in patients' mouths, we don't think of ourselves as researchers. We think of the researchers as the people in the big ivory towers. We need to change that. We need to take control as clinicians, and I'm both. I'm in academia and clinic, but throughout my career, in private practice throughout my career. We need to change that mentality. So I think it's a great point. I think getting back to the concept of releases and some of these articles that come out, they all just play it very safe. And they're like, well, we don't have the evidence to show it's helping airway. Yet when you talk to clinicians such as yourself who really understand this and live this every day, you can't ignore the impact it's having on these patients' lives, right?
Yes. And when we talk about, I'll give you an example as well that commonly comes up is exercises and myofunctional therapy pre and post tongue-tie release. I can tell you almost with certainty, I don't need an RCT to prove it, that if you don't move your tongue post-release, you'll get the scar tissue, it's going to grow back to be more restrictive than sometimes the original part. And this is highly debated in the UK and Europe because they say for a baby, for example, post tongue-tie releases, they have no evidence to show they improve. And the problem they do have is no one sees a patient post tongue-tie release. They're kind of being snipped in the hospital and they're being told, all right, you're done now. But what they miss is the big fact that the tongue actually can sit down on itself. So you think about your tongue, it's very easy for you to walk around this all day. And if you've got a wet wound, common sense tells us that that wound's going to join back because it's not being moved. Now, when you get cells and fibrin joining in, we've got the evidence all about wound healing, the different stages, etc. But the problem I see is people are not putting that evidence into one part and another. And it's very that, like you said as well, everyone wants, we need an RCT for this specific thing. Oh, wait, we can't take wound healings from this other area, like for example, implant dentistry, it doesn't apply to the tongue. Well, as far as I'm aware, the oral tissues are very, very similar. The floor of the mouth is not hugely different to other areas of the mouth as well. So, and the mouth kind of heals uniformly in one way, which is why I found tongue-tie releases very simple for me, because I'm already used as an implant surgeon to dealing with these tissues, to grafting on that side. And then that also got me to understand the healing part as well, which there is no evidence to say what can help post-surgical healing. I've been working with red light therapy the last few years because I get patients who are very sore, and we're told, oh, you've done a surgery, leave that patient alone, give them paracetamol, give them ibuprofen. So you guys call it Tylenol, and ibuprofen is, I'm trying to remember.
Advil usually.
Advil, there we go. Yeah, so you're told to give these patients Tylenol and Advil. Now, recently there's been a group of patients coming to see me who do not want to take any pain medications due to the other effects on the body. And what do we do to these patients? Do we say, all right, you suffer in pain? Then the idea came to me about using red light, which was being used in physiotherapy to deal with muscle soreness. I got a custom-made device for me, which looks like a curing light. And I said, okay, use this in the mouth. It's not going to do any harm. It's not strong enough to bend the tissues. It's LEDs. And my patient starts coming back to me like, this is incredible. I've got no pain. And I'm like, what? I said, this works. I was like, are you... Okay, even I doubted myself there for a second. I was like, how is this working? But in the end, it works. But is there any evidence to show it's going to work? There's not any RCTs to date, but then we do know the effects of photobiomodulation on healing, but it's on other areas, not the mouth.
Right. Yeah, it's such a good example of it, really. And on that note of the healing and the treatment, kind of as we're talking and splitting this up into different dimensions of the process, you mentioned before a little bit about when you saw it initially, and it was just scissors, and it was a very aggressive procedure. It wasn't anything that you saw yourself doing, and you really didn't feel like it was going to be something you could see yourself doing. As you started to learn it more and learn from people like Suraj and Baxter, what did you start to see them doing that was different, and how do you approach releases now in your own practice in all age, in different age patients? Does it vary by age? If you could talk us through that a little bit.
So the first thing was changing to a CO2 laser. That completely revolutionized my treatments because, number one, the bleeding is extremely minimal. Number two, you can actually, from that ray, see what you're releasing. And my patients were not as sore as when I used to do it with a diode or scissors. That was the big thing that I got from Dr. Baxter when I did his course, and understanding CO2 laser and physics and how it interacts with the oral tissues. When I did some more work with Suraj, the other thing I learned a lot was obviously myofunctional therapy, because then when you're moving the tissue, it's less likely to be sore, you get better outcomes, and then use of stitches. And that was something that even in my oral surgery residency, we were told never to suture the tongue. They said, oh, it's going to stop bleeding on its own, it's going to form a clot, you don't need to. But then you're leaving things to chance. You're leaving a big gaping hole and hoping it's going to magically heal together. But actually, you've got to think about and I compare this to when I do a soft tissue graft. I'm not going to take soft tissue from the palate and just leave it on my donor site without suturing it there, because it's going to stick together by a clot, etc. Now, you might be extremely lucky that it does, but you need to really fixate those grafts so that everything takes. Same with the tongue. We need to suture the area so that then we have primary intention healing and a thinner scar area to stretch afterwards. So those are the kind of things I learned from Dr. Baxter and Dr. Zaghi. And then the other thing I learned from both of them was working in a team. Now, Suraj is an ENT, so he comes to this from a completely different point of view. Dr. Baxter is a pediatric dentist, but both work with lactation consultants, osteopaths, myofunctional therapists, speech and language therapists. And like you said, it's vital to be working in a team on this way to get the best outcomes. And that's something before I wasn't so aware about. And now, after learning from both of them, I advocate for team play. You need to have your team ready. Even in our practice, we have an orthodontist, we have a myofunctional therapist, we have a speech therapist, we have 2 osteopaths, and we have a lactation consultant who's just down the road from me as well, and we make sure that everyone is all in close proximity.
That's such a big service, because that's a big challenge I find with people with whom I speak, is they might not have someone in their community to do one or more of these skills, to perform these skills for their patients. And it's hard for patients to find different providers. So it's really, really great that you've built a team approach to, and I know Helen Jones, who connected us, is amazing. And she had mentioned that you have such an awesome practice. She said you had held an event one time, and just such a great, lovely practice. And so kudos to you on what you've built there, because clearly this wasn't what you were trained to do necessarily, but you saw that you could help patients in this way. And then you not only did it in isolation, but you're building a team around you, which is really, really great. Because on the myofunctional therapy side, I find that people feel like myofunctional therapy has to go on forever. And I know you'd alluded to in some patients it may. What do you find is the appropriate average, obviously not speaking specifically about a specific patient, but on average for sort of, again, let's take those maybe 4-ish groups of patients, your infants and toddlers, your pre-adolescents, your adolescent to young adults, and then your adults. Are there some ranges for people that they should expect? Because I get that question all the time. People reach out, whether it's a patient, because I have a lot of lay people who listen to the show, or a provider, and say, they're just telling me I need to keep doing myofunctional therapy, and I either can't afford it or I don't have the time to keep doing it. So there's a lot of confusion about that. And I think it's actually hurting the overall movement towards something which is an amazing modality, which is myofunctional therapy, because people feel like this never ends. I'm never going to get out of it. So I've told a lot of my myofunctional therapy colleagues, I feel like they need to put some literature out or educate people as to this a little more. But what are your thoughts on that?
So I work with a really cool myofunctional therapist who's called Melissa Mugner. And what we
Melissa's great. She's actually been on the show and been on her podcast as well. So yeah.
She's amazing, isn't she?
Yes.
Melissa and I had a lot of discussions about how long treatment should be, because some people say 2 years, some people say a year, some people say 6 months. Now, it's, like you said, it's extremely customizable to the patient. And I think it's like going to the gym. We all know that we can do an intensive 6-week transformation, but it never stops there. You stop going, you start losing your muscle mass again, etc. And same with the tongue. Now, if I was to tell you a rough idea, I think for the adolescents and adults, it's about a year, give or take a few months. And then what I always tell them is you've just got to focus on your tone, very light stuff. And this can be either through devices such as we're finding the Spot Pal device works really well, the Replenish bottles, consistently training the tongue, or even just checking in with your therapist. But it's not as intense as the pre-release and post-release protocol at that point. For babies and infants, now, myofunctional therapy in babies is fairly tricky because obviously compliance is is not really there. Now, the few therapists I know who work with babies usually keep them in for a few months, and then they just keep an eye on them as they get to a year or so. But it's always a fairly continuous process. Like I would say, like I give an example, like training in the gym. You go, you work out, you get your muscles, and then you maintain them. Now, should you be under therapist's guidance all the time? In an ideal world, who wouldn't? Like, I would love to have a personal trainer with me throughout the rest of my life. But at some point, we've got to give patients the tools that they can do things on their own and then come and see their therapist if there's anything needed on that side.
That's a great explanation. Thank you for that. And that makes sense to people. I love the analogy, right? The personal trainer analogy, I'm going to ask if I can borrow that because
feel free.
Because it makes so much sense. It's yes, you could have a trainer there by your side all the time. And would you maybe do it a little bit better? Yeah, probably. But it's not practical for every workout. If you're someone who's going to work out 5 to 6 times a week, that you can afford or have the time, or that the trainer has the time to be there with you. I've always used the analogy before, but I like yours better, of kind of physical therapy as well, right? I'm a big fan of physical therapy. It's helped me a lot when I was practicing full time. It was more of an issue. It's not been since, thankfully, but when I was full time, in your elbows, your wrists, and your back, your neck. I mean, it's a physical profession what we do, and I would. You're static all day and then go to the gym in the evening and work out hard. And so as I got older, I noticed, I just noticed some of those creaks and aches and pains. Well, you go to the physical therapist and a lot of it was just an issue of range of motion. I was sitting all day and all night at my computer with my elbows bent, and then I'm going and extending my range of motion in the gym. So it took me 8 to 10 weeks of sessions to change my range of motion, learn certain stretches, learn certain weighted and unweighted exercises to help expand and not restrict my range of motion. And now I don't need to go to the physical therapist, but if something ever flares up, I know I can reach out and say, hey, I'm noticing this again, and they kind of can give you a touch up. So I think too, to my myofunctional therapy colleagues who listen, there's a lot to listen to the show. I think if that is something that you could make more well known out there, that would help a lot of people, because I really get the question a lot that people think that myofunctional therapy is not valid, when I want to be clear, I think it is incredibly important and essential to a lot of this. I feel like it's almost like we were saying before, it's like everybody who releases every tongue or the person who expands every patient. You create skepticism because you're not actually defining the parameters. And I know a lot of myofunctional therapists do a good job of this, so I'm not saying about everybody, but there are some, and I don't know who they are necessarily, but people reach out to me and they say, I'm being told I'm going to need intensive myofunctional therapy, or my child is, for 2 years, 2 to 3 times a week. Is that excessive? And it's certainly not my place to say yes or no. I just hear a lot of that, and I think it's turning people off on it, where your approach is, yes, pretty intense right around the event. And whether that's the expansion, the release, whatever we have our problem we're trying to solve, the airway breathing issue, but then the myofunctional therapist should be trying to wean you off of needing them holding your hand and you just doing this maintenance work yourself. Would that be a fair assessment?
Yes, exactly. I think a lot of the times, every myofunctional therapist I met works very differently. Some will want you doing therapy for about 2 to 3 years. Some will want you doing it just as short and sharp for tongue-tie release, a bit afterwards, and then kind of see how you evolve. And it all depends on each and everyone's kind of experience, I believe. And it's very difficult. There's a lot of times you'll have to probably go shopping, like with your dentist. You probably see one dentist and he'll say to you, you need a full mouth of root canals, you need crowns and bridges, or you need all your teeth removed. You might go to another dentist where you're like, actually, everything's okay. Hey, you only need 2 fillings. It's so subjective on that side. And I wish we had a bit more kind of uniformness to say, okay, this would be the best thing. But unfortunately, like with human beings, no 2 people are alike. And it's always good, from what Melissa and my therapists have seen, is start them off on a small way, see how they cope. Automatically then people either say, I want more, or, you know what, I'm coping well.
Yeah, that's a great approach. And again, Melissa's awesome. And I really believe in myofunctional therapy. I really believe in the value. And part of the reason I push my myofunctional therapy colleagues is because I don't want to see their message get lost by, just like I feel about early or interceptive orthodontics or releases. I don't want to see the whole movement and message get lost because some people are maybe overdoing it or over recommending it. I think, like you said, everybody could benefit from some element of therapy or physical therapy. It's that difference between survive and thrive. And if you try to tell every orthodontist they need a myofunctional therapist for every single patient they treat, you're going, whether or not that's true, and that's not my area of expertise to say that, you're going to lose a lot of people because it's not possible or practical for every family to afford that or to have the time for that, right? Or follow through on the exercises. So I think it'd be great if they could develop a little better scripting for the orthodontic community for the tremendous value that they can provide, the essential value that they can provide when they can provide it, and what that looks like for the average patient, knowing there's obviously standard deviations outside of the norm. But for that 80% in the bell curve, what does that kind of look like for your average crowded patient? Maybe they have a release, maybe they don't have a release, narrow arch, high vaulted palate, poor oral motor tone. Like, what does that kind of look like? And I think that would go a long way to helping orthodontists embrace the concept a little more.
And another thing as well, I think orthodontists, like with implant surgeons, we're judged by our failures. And I think orthodontists are always judged by relapse. And that's the one kind of thing we all, as dentists and perfectionists, we always want our treatment to look exactly the same as we finished it 10, 15 years down the line. And that's where one place I kind of find myofunctional therapy has a big goal now. Obviously, myself, I'm not an orthodontist. The orthodontists I work with, Dr. Biju and Dr. Eslam, they both like myofunctional therapy because they're like, my results are a lot more stable. And I also did a bit of perio training, so I'm not a big fan of fixed retainers just because I find they collect too. This is my own opinion, but I know where they're needed. But from an oral hygiene point of view, they were my nightmare patients when you got those fixed retainers and all of a sudden they become active.
I'm with you.
And
I can't stand them.
And you see that recession on the tooth, and you're like, why? Just wear your removable retainer. And this is also where I was kind of seeing is where the body will kind of push the teeth out the way to optimize breathing. And the body doesn't really care about straight teeth. The body's caring about oxygen. So if you've done a great orthodontic treatment, but you've not taken into consideration the myofunctional compensations, you're then going to be having to retreat this patient. And we all know retreatments are a lot harder than the initial ones anyway. But that's something I always tell, we spoke to my orthodontic colleagues about. I said, just imagine that these results would be very stable. And I think even Angle, the father of orthodontics, did say the tongue is the best space maintainer, best palatal expander, best retainer of all the teeth movements. And I think we've come so far from his message that now that we've times come that we should go back to those old teachings and look at them, because he actually had it right all those years ago.
Yeah. He actually also said in 1907, of all the causes of malocclusion, mouth breathing is the most potent, constant, and most varied in its results. So, again, those messages go a long way, and it's amazing. Before we had all this technology, the intuition of many of our forefathers in these areas. And I'm glad you said that, and I'll kind of ask you the last question I have here about myofunctional therapy in the role of retention. And I think a lot of the problem is orthodontists don't even understand or know what a myofunctional therapist can do or does. We don't know. We literally don't know. We don't think of it, even though we learn the equilibrium, the balance of the tongue and the cheeks. I mean, Ralph Frankel developed the Frankel appliance in the mid-60s. If you look at it, it had buccal shelves to keep the cheeks away from collapsing in on the arches, and tried to have some expansion components it was a functional appliance. He was a follower of Mel Moss and the functional matrix. So we've known for a long time that there's a tremendous role of the tongue, and the orofacial musculature has an impact on the dentition. But yet we are so tooth focused. We have such blinders on to anything outside. I would call it straight teeth bias. We have straight teeth bias. All we care about is getting those teeth straight. It's such a great point that we walk away from it oftentimes when it's straight and not in balance. And that becomes someone else's problem when we retire or the patient moves or whatever the case might be, and they have to be retreated or treated again. And I had a patient just 2 weeks ago reach out to me on Instagram. I finished her case in 2014. She reached out to me, tough case, herpes case and growth and development case. She reached out to me and said she's in North Carolina now, Charlotte, and she needs new retainers. And she sent me a picture. She has her original retainers from 2014. They're in great shape, but they're stained. And she said nothing she uses. And her dentist tried to clean them. They can't clean them. And so we're going to try to help her get her new set of retainers. But she said, every time I go to the dentist when I switched to North Carolina, and every time I go, they ask me who my orthodontist was and comment how nice it looks. And I don't say that as a pat on my own back. I say that because I really worked to create occlusions that would last. And I look at the ones that didn't last, because I'm not going to sit here and tell you they all didn't relapse. And I look at it and I wish I knew what I know now about myofunctional therapy and the role it could play, because I would be pretty confident that some of them, it was a lack of balance of the orofacial musculature, including the tongue.
I see the same thing. And I'm kind of part of that matrix as well, because I had 4 premolars removed for space reasons when I was about 13, and I still remember my mother asking the dentist, is there no way you can expand my son out? And the dentist goes, what do you mean expansion? Well, you know what you're talking about. And even at the time I was like thinking, yeah, she's right, can they not make it bigger or something? And luckily I'm still having to wear my removable retainers every night to make sure my teeth stay straight. But I agree with you. If it was, if I probably may have had myofunctional therapy at the point, I wouldn't be as reliant. But unfortunately, as dentists, we're always judged by the longevity of our results. And I think it's great to see that, obviously, it's, like I mentioned before, you're such a great orthodontist. I've heard so many good things from Helen about you as well. And it must be such a nice feeling to see your results, because you've taken the time to plan and treat that patient, last the test of time. And I hope the same with my patients, my implant patients, that I see someone maybe from about the 2015, 2016 time being like, my implant still looks perfect. So it's, and we all as dentists want to kind of achieve that perfection look, or make sure our treatments last, which in some ways we're chasing the human body, which is very, very, very unpredictable. But deep down inside it's what allows us to sleep. So, hey, if we can improve anyway, I'll always support it.
I'm actually going to let you have the last word with that. I think that's a great way to close it. It kind of encapsulates everything we've been talking about, right? Help our patients thrive, create that balance, that oromyofacial musculature balance. Look at all of it. Just because we didn't learn it in our training doesn't mean it's not a thing. Just because there's not a randomized controlled trial for that specific procedure doesn't mean it doesn't have validity. And always keep your patient's best interests in mind. And I think if you do that, you're always going to succeed in the short and the long term. Is there anything else you want to add to that?
You've said it very perfectly, but just I say to a lot of people, be a guide for your patients. Always show them what you see, paint a nice picture. Like I say a lot of time to patients, this is a restriction, it can go this way, that way. But unfortunately, none of us know the future. If we did, we would all be winning the lottery in a nice sunny place on a yacht on that side. But we can only tell you that with probability what it's going to be like. But in the end, I always give the final decision to my patients. I'm like, this is what you've got. This is what we need to do. But end of the day, this is your decision, just like you said.
Mm-hmm. Yeah, I love it. How do people reach you if they have other questions or they want to learn? I know you speak around the world as well and on this topic. So how can people learn more from you?
So you can always book and see me in my clinic in central London. It's Happy Kids Dental Chelsea, the tongue tie centre. My Instagram profile is at Dr. S. Vatish DDS, and you can always send me a message on that side. And Michael, I really want to thank you for having me on the podcast. It's been such a pleasure to speak to you, exchange ideas and speak to like-minded people. Even though we're miles apart, it feels like you're just in my living room right now next to me. So,
well, the pleasure's all mine. I've really enjoyed this conversation, and thank you for helping me understand this better and taking the time to walk me through it, because it's not an area that I am an expert, and I'm still learning a lot in this. So I appreciate you taking the time to thoroughly break everything down for me.
Anytime, and thank you again.
Yeah, you're welcome. Dr. Suraj Vatish, thanks so much. Appreciate you.
Thank you too.
Thank you for tuning into this episode of the Doc Podcast. Be sure to visit theorthocoach.com to get access to ADA CERP recognized CE courses or to schedule a private one-on-one coaching session with me. Also, if you know of someone who would make a great guest for this show, or if you'd like to be a guest yourself, please email me at drmike@theorthocoach.com. And be sure to join the Doc community on Facebook for more great content. Thanks so much for listening, and always remember, you have been blessed with the ability to do amazing things.